This is the Medical Masterclass's comprehensive guide to hematuria. We'll try to cover as many aspects of blood in the urine in this presentation. Just a little heads up before we begin, this presentation is intended for students of modern medicine and for medical professionals only. If you have any health related concerns, please seek professional medical advice. Alright, so what's in it for you today? We'll begin by talking about what hematuria is, then we'll try to classify it. Then we'll look for the common sources and causes for blood in the urine. We'll try to localize hematuria anatomically and follow that up with initial screening for high colored urine. We'll delve deeper into how urine dipsticks detect hematuria and the limitations of a urine dipstick test. We'll have a flowchart explaining to us the evaluation of hematuria. We'll go on to have a look at some interesting aspects such as RBC morphology in glomerular and non-glomerular diseases. We'll discuss selected mechanisms of hematuria and hematuria workup. Lastly, we'll wind up with some important pearls and pitfalls. So what exactly is hematuria? Put simply, it's an abnormal presence of blood in the urine. We most commonly analyze hematuria by urine dipstick and follow that up with microscopy. It is important to note that a dipstick evaluation of hematuria is not very reliable, as we'll see in a moment. There is no quote unquote safe lower limit of RBCs in urine, but a urine sample showing more than 3 RBCs per high power field warrants further evaluation. Hematuria is considered significant when there are more than 3 RBCs per high power field on more than 3 occasions, or RBCs are greater than 100 in number in a single urinalysis, or there is gross hematuria. So how do we classify hematuria? It can be gross, that is macroscopic, or asymptomatic and microscopic. Even small amounts of blood, that is 1 ml per liter of urine, can produce macroscopic hematuria. Microscopic hematuria includes RBCs greater than 8,000 per ml urine in phase contrast microscopy, or greater than 2,000 RBCs per ml urine as seen in light microscopy. Macroscopic hematuria is always abnormal except when menstrual blood has contaminated the urine sample. We can also have a transient hematuria due to strenuous exercise and bladder catheterization or due to trauma. Or we can also have persistent hematuria due to IgA nephropathy, Alport syndrome, drugs, etc. The common causes of microscopic hematuria can be classified into glomerular and non-glomerular. Glomerular causes originate in the kidney parenchyma. Non-glomerular causes are urological, mostly surgical, such as bladder cancer. Common sources of macroscopic hematuria are bladder, urethra, etc. Statistics states that macroscopic hematuria occurs in 70% people with bladder cancer and 40% with kidney cancer. Hematuria occurring in the first part of the stream is suggestive of urethral or prostatic lesion, and terminal hematuria is suggestive of bleeding from the bladder. Uniform hematuria has no localizing implications. When you see a patient with massive hematuria, he could be having radiation cystitis. That's an important differential to keep in mind. As we've seen, urine dipsticks are a good screening tool for high colored urine, but they're not very reliable. So when should you collect the urine sample for evaluation? Ideally, the second morning void specimen should be collected for microscopy since it has the most number of acanthocytes. We'll see what acanthocytes are in a while. In clinical practice, however, a urine sample collected randomly at any time of the day is used. Storage of urine at 4 degrees centigrade is mandated if not analyzed within an hour of collection. How do urine dipsticks detect hematuria? Urine dipsticks actually detect heme, which is a component of RBCs. Heme acts as an enzyme called peroxidase. Peroxidases facilitate chemical reactions involving peroxide. The area of dipstick designed for hematuria detection is coated with peroxidase and a color changing chromogen. Peroxidase is also present on the dipstick. When urine containing RBCs, which has heme, comes in contact with hydrogen peroxide on the dipstick, the peroxidase already present on the dipstick facilitates activity of heme and combinedly reacts with hydrogen peroxide and brings about a color change. So we see that urine dipsticks don't detect RBCs, they detect heme, and in particular its peroxidase activity. False positive may result due to heme coming from elsewhere, such as myoglobin from muscle damage. The dipstick might not be sensitive enough to detect very small numbers of RBCs in diluted samples. Medications can also interfere with dipsticks such as metronidazole, sodium hypochlorite, so can peroxidases and semen. False negative dipsticks in the presence of high urinary ascorbic acid or vitamin C is also possible, so a thorough dietary history of the patient is essential. Here's what a reference reading chart of a urine dipstick looks like. The red arrow points to the blood reference chart. To evaluate high colored urine, we said that a urine dipstick is a good initial screening test. If it is negative, it could be due to porphyrias, drugs like phenytoin, or foods like beet. It is important to remind ourselves that it could also be false negative, due to high vitamin C, for example. If the urine dipstick is positive for blood, we can centrifuge the sample at 2000 rpm for 5 minutes. If we get a clear supernatant, it implies that there are RBCs in the urine sample. If despite centrifugation the sample is still high colored, just let it stand for 3 hours. If it turns colorless, it is due to myoglobin coming from muscles, because myoglobin has a half-life of 3 hours. If even after standing for 3 hours the sample is still colored, it is due to hemoglobinuria. RBC morphology can tell us a lot about the source of bleeding. RBCs originating from urinary tract are similar in appearance to circulating ones, whereas those that have to travel through the glomeruli and tubules undergo morphological changes. So in our patients of hematuria, the presence of dysmorphic RBCs and RBC casts may suggest glomerular pathology as opposed to urologic pathology. The presence of dysmorphic RBCs and acanthocytes has high specificity and positive predictive value for glomerular diseases. The presence of RBC cast also suggests glomerular disease. Glomerular hematuria suggests alterations in glomerular structure ranging from overt glomerulonephritis to minor structural changes. That brings us to the question, how do the RBCs become dysmorphic? The average diameter of RBCs is 7 microns, which is about 100 times the size of endothelial fenestration, which is only 70 nanometers. Glomerular capillary hydraulic pressure, glomerular basement membrane integrity, and RBC membrane deformability is required for its diapedesis through glomerular basement membrane. In this electron microscopic image, you can see the RBC passing through the glomerular capillary into the urinary space. Passage of RBCs through disrupted glomerular basement membrane might alone be sufficient to twist and distort the shape of RBCs into a dysmorphic one. There are also other factors at play, such as alteration due to lysosomal exocytosis and inflammatory cells releasing proteases that can disrupt the RBC framework made of spectrin. Membrane alteration and fragmentation can also happen due to differential pH and osmotic forces in tubular fluid, resulting in dysmorphic RBCs. RBC casts may be formed around the TAM horsefall protein scaffold, which is a glycoprotein found in urine. When we talk of microscopy, phase contrast microscopy is the best when we want to visualize acanthocytes, which are distorted RBCs with blebs, as you can see in the pictures. Here's another image of erythrocyte cast, which is formed by RBCs scaffolding around TAM horsefall protein or uromodulin. And on the right hand side, you can see an acanthocyte with a protruding bleb. What's the difference between glomerular and non-glomerular hematuria? Glomerular hematuria, as the name implies, originates in the glomerulus due to kidney diseases, whereas non-glomerular hematuria originates in the lower urinary tract due to infections, prostate problems, kidney stones, etc. Glomerular hematuria is slightly brownish due to RBC breakdown products, but hematuria of non-glomerular origin is fresh and red. Proteins and RBC casts are often found in glomerular hematuria and not so in hematuria of non-glomerular origin. Glomerular hematuria may be sudden or gradual in onset and is often painless, but non-glomerular hematuria is often associated with a recent injury or a recent infection and may be associated with flank pain, burning micturition, etc. We'll have a look at selected mechanisms of hematuria. We begin by looking at BPH. So in BPH, there is increased prostatic vascularity due to increased microvessel density in a hyperplastic prostatic tissue. This is due to a high VEGF level. BPH is the most common cause of gross hematuria in the elderly. Hypercalciuria results in excess tiny microscopic calcium compound crystals in the urine. They can irritate and damage the lining of urinary tract, nephrons, and collecting ducts. Microscopic hematuria is associated with hypercalciuria and is more commonly seen in children than in adults. Exercise or sports hematuria can occur due to the bladder's posterior wall impacting against the bladder's base. Dehydration can worsen the situation. Some people with psychiatric disorders such as Munchausen syndrome may present with macroscopic hematuria to gain medical attention. This hematuria is artifactual. Some individuals may seek opioids by stimulating renal colic and macroscopic hematuria. It is essential that such patients be made to pass urine in the presence of a suitable witness and the sample be then collected. Since it is relevant to the ongoing discussion, we'll talk a little bit about urethral caruncle, which is almost exclusive to postmenopausal females and is a benign granulomatous tumor in the distal urethra. It is tender and bleeds easily and causes hematuria, which might cause concern, so the woman may require cystoscopy and biopsy for diagnosis. It can be treated with laser vaporization, cryotherapy, cautery, and surgical excision. Urine dipstick is a good initial screening tool for hematuria, as we have seen, but we must follow it up with microscopy. UTIs can also cause hematuria, so urine culture also has its own importance. Urine cytology may be important in detecting malignancies of the bladder. Appropriate blood tests according to the patient history may be ordered, such as PSA if the prostate cancer is suspected. We also have the option to directly view the organs involved using ureteroscopy, cystoscopy, and ureteroscopy. Kidney biopsy is indicated for glomerular diseases. We will wind up, there are some more radiological aids in the hematuria workup, which are IVU, IVP, but they were previously used as the key investigations, but now they've been largely superseded by CT. USG is less sensitive in detecting lower urinary tract abnormalities but is still used. CT can be used with or without contrast. MRI, kidney angiography, retrograde pyelography is also used. We will wind up this presentation by going through some pearls and pitfalls. Painless gross hematuria is the most common symptom that is indicative of a bladder carcinoma until proven otherwise. Painless gross hematuria in an elderly man is indicative of benign prostatic hyperplasia. Hematuria associated with glomerulonephritis is typically painless. The most common cause of microscopic hematuria in children is hypercalciuria. Acute hemorrhagic cystitis is a benign and self-limited viral UTI. Adenovirus serotypes 11 and 21 cause acute hemorrhagic cystitis in children. While UTI is a common cause of microhematuria, the resolution of microhematuria after UTI treatment should be documented, as malignancy and UTI may coexist. Normal children will have positive urine dipstick for hematuria 1% to 4% of the time. Unlike adults, hematuria in children rarely occurs due to an underlying malignancy. Careful history taking is essential, including a thorough drug history of blood thinners, cytotoxics, etc. I thank you for your time and attention. If you liked the video, please consider liking, subscribing, and sharing. Thank you.